So, our first speaker tonight is Dr. John Brownstein, PhD, and John is an associate professor at Harvard Medical School and directs the Computational Epidemiology group at Children's Hospital Informatics program in Boston. Overall, his research agenda aims to have translation impact on the surveillance, control, and prevention of disease. Dr. Brownstein has advised the World Health Organization, the Institute of Medicine, the U.S. Department of Health and Human Services, and the White House on real-time public health surveillance. And he's here tonight to talk about public health surveillance. Please give a very warm welcome to Dr. John Brownstein.
Fantastic. Okay, great. It's wonderful to be here today, tonight. This is definitely not the usual audience I speak to, so hopefully you'll learn something new. I'm not a text analytics expert. I'm an epidemiologist, but we've used text analytics essentially as a way to transform the way we do public health surveillance. So I'll sort of go through some examples about how we're using these kind of methods in practice. So I'll start with an example. There was a conference a couple years ago in Canada, in Victoria, BC, where they started exchanging information about the conference using hashtag Nash74. So as part of that, all of a sudden we get one tweet, motion that nobody else on this bus puke, hashtag Nash74. That sort of led to a whole number of tweets that started discussing a gala event that took place where essentially a puke fest, where everybody at that gala event was getting sick. Don't take the stairs in the basement. In fact, people talking about a zombie horror film unfolding, pictures of the ambulance actually arriving to the gala event, and then within 36 hours, the events had sort of slowed down, and the norovirus outbreak that took place basically ended. So what's incredible about this is that social media is transforming the way that we know about disease outbreaks. We're not getting these from sort of traditional public health measures through traditional laboratory reporting. These are coming through these incredible new channels, and they're coming through through text in sort of new ways that we're having to deal with. But excitingly, we actually get to understand what's happening in populations at a level that's completely different from what we've known before. So for instance, CDC reports about 1,000 foodborne outbreaks that take place every year, but through the systems that we're working with, we know that that's at least tenfold greater. The kinds of events that are taking place just go unreported, and really our true understanding of burden is completely wrong. And so we're trying to revise that to really understand what's happening in populations. Let's take Yelp as an example. I'm sure people use Yelp here. I don't know if you knew that 10% of all Yelp reviews are food poisoning related. And so maybe you did know, but that's just one example of a place that I won't name in Boston. But the reality is that we can start to extract that information and look for particular tags of foodborne illness, but also specific ingredients, foods that were implicated in that illness, and we can start to look at that to understand sort of how that relates to what we know, what comes through the channels via CDC as an example. And incredibly enough, the kinds of ingredients people implicate in foodborne illness are exactly the same as what comes through the sort of more official channels. So much so that actually, say, New York City is working with this kind of data to actually inform their outbreak investigations and look into restaurant inspections based on Yelp data. But Yelp is only a fraction of the data out there. In fact, there's an incredible vast amount of data, say, coming through Twitter. We're recently recipients of a data grant that got us access to close to 1 billion tweets, all of which are mentioning some level of foodborne poisoning. So once again, we're able to somehow extract that information and begin to revise our understanding of these events. So the goal of what we're doing is trying to think through all the various channels of communication about health events and organize that information to provide us early information about what's taking place in populations. And our thesis is that by using this kind of data streams and organizing them properly, we can actually understand these events way earlier in populations. And by understanding what's happening, we can actually act and mitigate the impact of a major outbreak, a major pandemic. And in fact, we can also begin to revise our understanding of the distribution of disease, where in many places around the world, there's limited in public health infrastructure, limited reporting, limited transparency. We can revise our understanding of where disease actually is in populations. And that's really critical because we know that the speed at which information flows generally in traditional health systems is actually very slow. It takes days, months, weeks before anybody knows that a major event like a SARS outbreak or more recently MERS is actually happening in populations. And so the goal of what we do is try to unlock information from sort of informal data streams that are often very noisy but holding extraordinary value for us to actually make an information system that actually is available to everybody simultaneously, to all stakeholders in the event of a major outbreak. And this has actually informed a whole new field of digital disease detection, where we're harnessing these kind of sources to actually build new tools. And one of those tools is a system that we run called HealthMap, which is this global online aggregator of information that basically pulls in as many data sources as we can get our hands on via news, social media sites, clinician chat rooms, organizes that input information across 15 different languages with the idea of identifying new disease alerts around the world, and then geocoding those through the text mentions of locations. So example, we find a text, either it's a mention on social media or a news site, we can take the mentions that come through these channels that were scattered around the web and not really well organized, and start to categorize this data by disease, by location, by case counts, and a fairly high resolution of geocoding to essentially organize that content into a structured database. And that's really where the information becomes valuable. Spread across the web in sort of unstructured text, it's very hard for any public health official to understand what's going on. You start to bring that data together, and all of a sudden now you have a useful system. Of course, you have to do lots of things like spam filtering for the kind of content that you're interested in, filtering out. Recently we had the World Cup football fever, those kind of things, removing those kind of articles, and actually organizing the text that's useful. Finally, there's a huge amount of effort that goes into classifying the importance of the events, but also duplication. You can imagine social media, huge amount of echo chamber, same events being reported over and over and over again. We have to do cluster analysis of the same content, organize it, and then essentially create a feed of information that becomes useful for the end user. That could be clinicians, the general public, public health officials, governments that use this data for day-to-day surveillance efforts. So one example is H1N1. I don't know how many people remember the events of swine flu in 2009. I assume you do. The first reports of those events did not come from the CDC. They did not come from the Ministry of Health in Mexico. It came from a local media source in Veracruz, Mexico, that was talking about a mysterious illness that was taking place across the population. And it was only through the existence of these data systems that could scrape this information, organize it, and make it available back to public health that this information, this one local news source, would be actually of interest to anybody, say, sitting at the WHO. If you fast forward 5 years to H7N9, which is a new flu strain that's emerging in China, it's a completely different ballgame. Whereas maybe in the time of SARS, we had very limited information about what was taking place in the country. Now, all of a sudden, we have Weibo, which actually provides this incredible level of detail on cases that are coming into hospitals. And 10 years ago, we had almost no information coming out of China. Now we have people that are taking photos of electronic medical records and posting those to the social media sites, forcing governments to actually be much more transparent about what's taking place. It's also, this kind of data is also helping us revise where risk is around the world. So I don't know how many people are familiar with dengue. It's an important emerging virus, mosquito-borne virus that takes place worldwide. It's not prevalent in the US necessarily, although just probably in Florida to a certain extent. But our understanding of where risk is in the population is completely wrong. So often, say if you go to the doctor to find out what kind of viruses you might encounter when you travel, the data that you look at is often 3 years out of date. You really don't have a good real-time understanding of where the risks are. So the idea here is you can extract the kind of information we're collecting and integrate that back with data from, say, CDC and other sources to actually come up with a new definition of the distribution of risk. So we're using these data sources, these informal sources, although potentially much more noisy, they provide us a great amount of sensitivity to the leading edge of the new distribution of disease. So that's one area of work that we do, and it's a big part of our efforts as we try to provide what we call epidemic intelligence to government agencies. But we also recognize that the online sort of social behavior also provides incredible data on the health status of populations. And so the idea is, can we get novel insights about what's happening in populations based on what people do online? And often what we realize is the things that people say and do online are completely different than the things that they might actually report to clinicians. And actually, so it's data that may not ever show up in an electronic medical record. And so the one area that we especially focus on is the area of medication use. We know that medications often account for huge numbers of adverse events so issues that relate to the products that one is taking. But what actually FDA knows about in the population is a very small segment of what's actually taking place. So our understanding of people's interactions with pharmaceutical products, drugs, there's a whole wide range of issues that people face. But the problem is people don't even know to report bad reactions to the FDA. So there is very limited data that comes through. So why not just go to where patients are, whether they're on social networking sites, patient sites, and organize that information and make that available back to the FDA. So we've been spending a huge amount of time in the text analytics area around organizing the people's discussions around drugs on social media sites. There's only a small segment of useful information, so we spend a lot of time trying to filter out the noise. And then, at the same time, spending a huge amount of time building up new taxonomies. So the idea is when we are faced with this kind of an issue, we're constantly trying to translate internet vernacular back to a medical taxonomy that makes sense. So we're constantly dealing with the usual things like typos, spelling variations, invented words. The hashtag concept is not something you would generally find in an electronic medical record, but it's a new kind of data source that we need to use and actually match to outcomes. And then implied phrases. So the idea is, in a clinical note, you're never going to see someone like a doctor write never wants to eat again, or eats like a mouse. But so these are all new types of structure that we're trying to build in to these new taxonomies to essentially take that kind of data, organize it, and link it back to coding that makes sense from a regulatory perspective. So we're interested in how we organize internet vernacular and make it sense to, say, a FDA drug reviewer that wants to know what the problem medication is in the population. So that's a big area. But there's also lots of behaviors that we're collecting online that are sort of more from the illicit side of things. So we're constantly, and I don't know if people can see the kinds of things that are coming through on Instagram, but it's, the grandma gave me some Percocet. She came in clutch. I mean, so there's some incredible things, and these are not niche drug abuser forums. These are actually right out in front of us on places like Instagram, where we can start to mine and understand the types of products, the issues that are happening in populations. What's really amazing to me, there's actually, people are full on taking photos of the products they're about to sell on Instagram and making people aware of what they have. This is actually my favorite, the smiley face. But the reality is that that data actually is helpful from a public health perspective. We're mining that information and identifying pricing for these different products. And that might sound crazy from a public health perspective, but actually what we're trying to do is understand the various impacts of different opioids in populations. OxyContin, I'm sure everybody in the room has heard of it, or maybe used it. But the idea is that pricing for OxyContin changes and is the black market is very intelligent to shifts in the product. So for instance, OxyContin has a new formulation that is abuse deterrent, so it's harder to crush and get high off of. And so as soon as that happened, the price dropped dramatically. So through all these channels, we were able to see that the pricing completely shifted, and that actually is very positive from a public health perspective, that the drug is actually reduced in abuse, although people are shifting to other things. So we're tracking that as it moves. And things like sites like Silk Road, which used to be around, actually were helpful in informing us of that. The last example that I'll mention is in sort of not necessarily health outcomes, but people's attitudes and beliefs towards health outcomes, so or sort of public health prevention. So as you might know, and if people here are on social media, they probably see a huge amount of discussion about vaccines. I'm sure you've seen a lot of discussion about the autism links and every million and one things that are wrong with vaccines. Well, we can arm public health with the knowledge of what's actually transpiring online and organizing the content about rumors. And so the amount of data about rumors on vaccines is overwhelming. And the only reason that the US is not on here is that it's about 10 times greater than every other country on Earth in terms of every possible rumor that you can imagine, but every vaccine. But what's exciting is that we can start to monitor the conversation about, say, the sentiment towards vaccines and actually understand sort of, say, HPV vaccine, what is the general attitude in the population towards HPV. And you can also see external factors like Michelle Bachmann making a statement about the HPV vaccine and all of a sudden negativity rising dramatically because of things that were said and misconceptions. So we can arm. Not that we have all the solutions of what public health can actually do once they know that these issues are there, but at least we can arm them with the emerging issues that are coming up. So I'll just end with the idea that, of course, this big data area has also derived a huge amount of hype. I didn't actually mention Google flu trends, but obviously there's a lot of different efforts that have happened in this space, and it's brought in a lot of hype and excitement about the potential of these data sources, but I think we've seen a lot of backlash as well that's happened. I don't know how much people have followed the press about whether big data really is that sort of silver bullet that can actually get us some useful information about population health. I'm sure you've seen some of the articles and some of the issues that have come up on privacy, and actually even the Facebook study that happened recently where there's potential tweaking of people's emotions. And so I think there's still a lot to learn, and I think there's a lot to learn from sort of working with Silicon Valley and companies and how to properly do research with this kind of data. And so there's a whole field. So the people that are in this room that are interested in this space, there's a lot more to be done in this from the analytics side, from the privacy side. It's a whole field that has a lot of excitement, but also a lot of challenges as well. So I'll leave it there. I thank the funders for this work and the group that's just down the street in Boston at the Boston Children's Hospital. Thanks a lot.
John, while we're setting up the next one, do you mind taking a question or two?
Sure, be glad to.
One or two questions, please.
Yeah, go ahead.
What techniques do you use to translate or define the kind of vernacular for these different actual medical coding values?
So, I mean, it's pretty crude, actually. So, I mean, we have experts. So we rely a lot on sort of training sets that are developed by experts. So we use Iterator Agreement, but we have people that are epidemiologists that spend huge amounts of their day just looking at mentions in text and extracting those segments in the text that relate, then translate that back to various codes that make sense from the medical taxonomy. And so we're constantly building up those taxonomies over time through curation, and then we're able to move that use that dictionary going forward.
One more question?
Yeah, I see it. All right. I don't know, I'm pointing down, yeah. Go ahead.
You already mentioned about the Google flu predictions.
Yeah.
And the big data is as good as the question you frame. So what is the predictive value of this text analysis, and how do you go down to framing a right query?
Yeah. That's a good question. That's hard to answer in a short amount of time. I mean, the Google issues obviously, came from the place of, they perhaps asked the right question, but they were not understanding sort of the underlying context of the data and how it changes over time. So, for instance, people's types of queries they use online to reference flu changes over time, and they didn't really modify their models. They weren't just reiterating their models over time. So, I don't think there's any general sort of framework. We're still trying to think through sort of the value of these data sets in a lot of different applications. I think that one has to be very careful about understanding the biases and not sort of so the data represents the segment of the population that you're looking at. So it's very hard to sometimes generalize to the broader population, and I think people have to be very careful in how they couch the conclusions from the data, not overextending. So, for instance, the work that we're doing with the FDA, these are not definitive signals that we're saying, okay, now you have to withdraw the product. We're saying, okay, this is insight that might force you to do a deeper investigation in more sort of individual level data and clinical records. So I think it's about making sure you're framing the sort of the value of the data, not pushing it beyond where it can go. So. Thank you.
Thank you for an excellent speech.